So now we'd like to move to Dr. Greg Albers, who will be presenting his expertise and to both the clinical and technical side of stroke diagnosis. He's going to walk us through the interpretation of CTP imaging and collaterals. His presentation will then be followed by the panel discussion, and we're going to explore various clinical scenarios and steps in the clinical decision-making process. So please, Dr. Albers, take it away.
Very happy to be able to participate in this meeting. My topic is interpretation of CT perfusion, which you already heard was very valuable for helping to decide, which patients should be transferred into Anchorage. And I suspect this is something that you were not taught in your medical education. So I'll take the advantage over the next 25 minutes or so to provide some insights into how to interpret CT perfusion and what the value of CT perfusion is. You've heard about helping with transfers, but it is also incredibly helpful with diagnosis. When a stroke patient arrives, one of the first questions that one has is this a stroke? And how big is the stroke? Where is it? How much salvageable tissue do we have? So sorting out whether this is a true stroke or a stroke mimic, or what I'll call a stroke chameleon, as you'll see in a minute, is really something that perfusion can be very, very helpful for. It's also been shown to be extremely helpful for selecting patients, particularly in the late time window, for treatment with thrombolysis or thrombectomy. So this is an example of a case here that on first glance, you may not easily see what the problem is if you look at the CTA at the top right. But when you have the CT perfusion with it, you can very quickly identify that this is a middle cerebral artery branch occlusion on the right. And once you have the perfusion, it makes it easier to go back to the CTA and find exactly where that occlusion is. All right, so let's talk about stroke mimics. So this is a patient who presents with no verbal output, does not speak, does not seem to respond to commands, has an otherwise normal neurologic exam. We see several of these patients each year. And one of the questions is this patient having a severe aphasia from a left hemisphere stroke? The CTA comes back normal. The non-con CT is normal. And people might be reaching to give TPA or TNK, but when the perfusion image comes back and is completely normal, no abnormality of arrival of blood flow to the brain, normal cerebral blood flow, what this tells us is that this is a stroke mimic. So there's a number of things that can mimic stroke, including migraines and seizures. In this particular patient, it was a stress reaction, what we call a functional reaction. Sometimes stress can be manifest as neurologic symptoms, and that was the case in this individual. So clearly did not need treatment with TPA. Here's another one, and people have often argued for a patient like this, why do any imaging at all? It's so obvious there's a massive left hemisphere stroke going on. Why don't you just go straight into a cath lab and have the clot pulled out? So it's a patient who comes in with a severe global aphasia, right-sided weakness, high NIH stroke scale. And if this patient had gone straight to the cath lab, they would have found that there was no occlusion in the left carotid or middle cerebral artery. And the assumption might have been, well, this patient must have had spontaneous recanalization. It seems so obvious they were having a stroke. But if a CT perfusion had been performed, what you would see in the left hemisphere is very high blood flow. So increased blood volume, increased blood flow, and early arrival of the contrast. And that's something that's typical of a seizure. So this patient had non-convulsive status epilepticus. Obviously, a very different treatment would be indicated rather than rushing to the cath lab. Okay, so you saw a couple of stroke mimics, things that look like a stroke but were not. How about stroke chameleons? So that's a patient who's actually having a stroke, but it seems like it's something else on initial presentation to the ER. So here's a picture of a couple of different chameleons that are masquerading as leaves. And so let's take a look at a couple of chameleons that where we have somebody who presents with what appears to be a different diagnosis, but actually has a stroke. And this particular chameleon is a very dangerous one. It's also a very expensive one because one of these cases led to a $110 million lawsuit that was settled against a hospital in New York just a couple of years ago. And multiple other lawsuits are ongoing for this particular chameleon. So this occurs usually when you have a patient who is a younger individual with a history of substance abuse, comes in with altered consciousness, and the initial knee-jerk reaction, of course, is that this is a drug overdose. But when the alcohol level comes back negative and the drug screen comes back negative and the patient really didn't wake up much with the Narcan, eventually this diagnosis can be made. And it is easily made in the vast majority of cases with CT perfusion. This patient has a clot in the basilar artery. So this is a basilar artery thrombosis. And we know that we can have very effective treatment responses by pulling these clots out. And here, seeing the pattern of abnormal blood flow in the cerebellum and brainstem can be very helpful to tip you off that you're dealing with a basilar thrombosis. Here's another one which we see a number of times a year and is kind of frustrating. Is a patient who comes into the ER with a complaint of visual loss in one eye. The ER assumes, based on their initial exam, that this is monocular visual loss. So they call opto. Opto, even at Stanford, is not too responsive to rushing over to the ER. They usually say, we'll be by after clinic. But the CT perfusion in this case shows that there's a perfusion deficit. You see that green area in the back of the brain on the right side of the brain is in the posterior cerebral artery distribution, affecting the visual areas of the occipital lobe. So this patient is having a stroke causing visual loss, and it's actually a visual field deficit rather than just a monocular problem. All right, so you've seen some examples here on how perfusion has helped us sort some tricky cases of mimics and chameleons. And now let's talk about how this CT perfusion is created and how do we really interpret this most accurately. So to create a CT perfusion, you give a contrast bolus into a vein with a power injector, and then you watch as that contrast bolus enters an artery in the brain. That's the red waveform there. It's called the arterial input. And then you watch as that contrast bolus exits the brain through one of the venous sinuses, and that's called the venous outflow. And that's the blue waveform that you see on the graph. From these waveforms, you can create maps that will depict the cerebral blood volume, which is the area under that arterial curve. You can look at the cerebral blood flow, which is related to that maximum slope of the curve. You can see if there's a delay in the arrival of contrast, which is from the bolus arrival time, and the time of the peak, which is shown as TTP there. So you can generate all sorts of maps that can be useful in sorting out what's wrong with the patient. So let's take a look here. This is the mismatch map, which is the first map that comes out. And it's a very basic map where on the right, the green areas are showing regions of the brain where the contrast arrived more than 6 seconds too late. So based on the normal blood vessel arrival time, which was that red curve, the AIF, arterial input function, you look for how much delay has occurred out in the tissue. And if it's more than 6 seconds, it's colored in green. That 6 seconds comes from studies with PET scans that show that amount of delay corresponds very well to the penumbral threshold, which is 20 milliliters per 100 grams of tissue per minute. So basically, you're estimating tissue that is critically hypoperfused and likely to go on to die in the setting of acute stroke. On the left side, you see the pink area, and that's an area that has very low cerebral blood flow. So what the software that analyzes the perfusion scan does is it starts with the green map, and any area that's not green is assumed to have normal cerebral blood flow. So you can see that all of the left hemisphere and part of the right hemisphere looks like it has no delay. So you calculate the average cerebral blood flow for that patient, and then you can look at a reduction. So any area that has more than a 70% reduction is likely to be severely ischemic and likely to die. So CBF less than 30% means that the tissue in pink there, shown on the left side, has less than 30% of the patient's normal cerebral blood flow. So in this case, you can see it's a very small volume, only a small volume that is irreversibly injured, and the green area is a large volume that is potentially going to go on to die. So this is going to be very helpful in assessing the size, location, and severity of the stroke. But what I'm going to show you now is a case where there's no pink or green. And this is a case where we still can get a lot of information out of the CT perfusion. So this is a very complicated case. We're going to look at it briefly now, and then we'll come back at the end and take another look at this case. So if there's no green or no pink, that doesn't mean you should ignore the map, because these are grayscale images. And if we start over on the right with the Tmax maps, what you can see is that there are some areas that are very bright white, and there's some areas that are dark. So, for example, the ventricles are bright white. Bright white means the contrast never got there. Obviously, there's no blood flow to the ventricles, so the contrast never gets there. Areas that are bright outside of the ventricles also mean that there's a delay. And you can look at the front of the right hemisphere and you see a bright white area. And if it's that bright white, it suggests that no contrast has ever got to that area in the right frontal part of the brain. In other words, there's no tissue there. So this suggests there's an old injury. What we can also see here is that there is this white thin line capping the top of the brain. And when you see that white outline of the brain, like a thick white marker around the part of the brain, what that tells you is the patient moved during the scan. So it's giving you a hint that there's movement, and movement can cause some artifacts. Okay, the other thing that we notice, if you look at the right side of this slide here, that the entire right side of the brain is brighter than the left side. So what that tells us is that there's some delay in the arrival of the blood flow to the entire right side. There's an area that's super bright white where there's no tissue, but there's also an area that's mildly bright, which means that there's a delay. The delay was not 6 seconds. If it was 6 seconds, it would have been green. So this might be a 4 or 5 second delay, but that still could be an important delay. Let's now look to the left side of the slide where it says CBF. And this is also a grayscale map. Now, if you look at the ventricles here, you'll notice they're black, not white. So in this map, zero blood flow is black. There's no blood flow to the ventricles. That's all CSF. So we can look at other regions of the brain that are black. And again, that right frontal region, we see that big swath of black there, which suggests there's no brain tissue there. So there's some type of old encephalomalacia, some old brain injury in the right hemisphere. If we look directly below that to the occipital lobe, what we can see is very bright tissue, brighter on the right hemisphere than on the left. And what that suggests that there is increased cerebral blood flow. So increased cerebral blood flow can happen for a few different reasons. It can occur in somebody who's having a seizure. It can occur in somebody with a migraine. It can also occur in patients who've just had a blood vessel opened and the blood vessels are all dilated and because the blood vessel was blocked. So there's different reasons for this, but what this is telling us is we have increased cerebral blood flow in the back part of the right hemisphere, and we have no cerebral blood flow in the front of the right hemisphere. So clearly this is a complicated case, but the point is that just because you didn't see any green or pink in the mismatch map, that doesn't mean you're done. Take a look at the map for asymmetries and see if you can figure out whether there's delays in contrast arrival on the Tmax or abnormalities of CBF either reduced or increased based on the CBF map on the left. Okay, so let's go beyond the mismatch map now. The next thing that comes up after the mismatch map is what we call the 4-threshold Tmax map. So in the mismatch map, you just had an all or none. If it was more than 6 seconds, it's green, but it doesn't tell you if it was 8 seconds or 10 seconds. It also doesn't show you if it was less than 6 seconds. So here we get 4 different thresholds. If it's 4 to 6 seconds delayed, it's blue. 6 to 8 is green. 8 to 10 is yellow. And more than 10 is red. Why is this important? Well, because the areas that are red have severe delays. In other words, very poor collateral flow bringing in the contrast material, and areas with poor collateral flow are going to grow quickly. The other reason is that it's important to look here is the blue area. The blue area means there is some abnormality of blood flow, but it is not yet raised to a threshold that it is really threatening that brain tissue survival. However, that's an area that potentially could easily become at risk. Suppose the blood pressure drops a little bit, then that blue area could turn into a green area where we have a critical hypoperfusion. All right, so we can get a couple of very important collateral indices from the perfusion map. The first one is called the hypoperfusion intensity ratio, and that's very simple. So from the 4 threshold map that I just showed you, you take the volume that's red, that's the severe delay, and you put that divided by the volume that is greater than 6 seconds. In other words, the volume that you saw on the mismatch map is being critically hypoperfused beyond 6 seconds. So this is going to give you the percentage of the perfusion deficit that is really bad collaterals. So if you have a low HIR like this, it means only 20% of the perfusion deficit had very bad collaterals. If that HIR was 0.9, it would mean 90% of the perfusion deficit had bad collaterals. And numerous studies have been published that shows that the growth rate in the first few hours of stroke is directly related to this HIR. A low HIR like this will not grow in the first 2 to 3 hours. So this is a great patient for transfer. If this patient had an HIR of 0.8 or 0.9, we could be confident that they were going to have substantial growth over the next few hours. Another measure, a complementary measure of collaterals, is what's called the CBV Index. And that's shown here on the right. So what we're looking at is the amount of blood volume that is present within that Tmax 6 area. The area that was green on the mismatch map will look specifically there and say, is the blood volume preserved? If the blood volume was preserved, that would be 100%. So that would be our CBV index of 1.0. And our CBV index of 0.6 means that there's 60% of the blood flow, the blood volume in that region. So anything below 0.7 is poor collateral. So if you see CBV index of 0.6, as in this case, that means we do not have collaterals. If you start to get down towards 0.5 or 0.4, that's going to indicate, again, a patient who is having rapid growth. If the index is above 0.7 or 0.8, you're going to have slow growth. So the combination of looking at how well the brain has been able to maintain volume of blood into the ischemic area, which is the CBV index, along with the HIR, gives you a very comprehensive feel for what the collateral circulation is, and it can make an accurate prediction of how much that stroke is going to grow when you transfer the patient over several hours to get to anchorage. All right, let's now move on to the question of the cerebral blood flow threshold. What I showed you in the mismatch map was a cerebral blood flow threshold less than 30%. That means that we're showing tissue that has more than a 70% reduction in blood flow. In other words, the blood flow in the colored area is 30% or less of what it should be. So that's the standard threshold that's used for assessing tissue that is highly likely to be irreversibly injured. That is picked to be a conservative threshold. The threshold that actually more closely matches with the diffusion image is less than 38. So you can see in this case, less than 38, which would more closely match an MRI scan, is 130 ml. But what's being reported in the mismatch map is 106 ml. And the reason is because the 130 ml in a small percentage of cases can overcall the tissue that is irreversibly injured. And we don't want to overcall that. So we put in the mismatch map a more conservative value to try to avoid overcalling tissue to be dead, because we certainly wouldn't want to treat a patient because we thought a lot of tissue was dead and it actually wasn't dead. So this is how the 30% came about. It's a conservative threshold. Now, there's one exception where we don't want to use the 30%. We want to use an even more conservative threshold, and that's the golden hour. And we define the golden hour generously as 90 minutes rather than 60 minutes. So if a patient is scanned within 90 minutes, we're going to use the 20% threshold. So an even more strict definition of core, because to kill brain tissue, you need low CBF for an extended period of time. If you have really low CBF for 5 minutes and then you reperfuse the vessel, you have a TIA, no irreversible injury. So we're taking the concept of time in here. So if you're fortunate enough to scan somebody within the first 90 minutes, then you have this 20% threshold, which is presented on all of the rapid images, and we will use that. So in this case, you see the 20% threshold was at 29 ml of irreversibly injured tissue. 30% was much larger. And you can see the follow-up infarct matched the 20% value much better than the 30%. So again, this doesn't come into play very often because we don't typically get patients showing up within 90 minutes. But if it does, we're going to use this more conservative threshold because we want to avoid overcalling the core. People call that ghost core, and that can be effectively avoided by using the proper thresholds. All right, the other thing that you get, the next map is called the image columns. And this is a super helpful map because it gives you a co-registration of the CT scan, the basic non-contrast CT scan, along with these various maps. And here, no thresholds are applied. You just use your eyes to see what's abnormal. So if you look at the CBV map, which is the first one after the non-con CT, dark blue means very low blood volume. Very low blood volume is very bad. If you don't have blood volume, you're going to infarct quickly. So you can see the area of dark blue is the area that's in big trouble there with very low blood volume. And you can see that's a little bit smaller than the area with low blood flow. So the dark blue area on the next map, which is the CBF column, is going to show you area that has low blood flow, but some of this might be reversible because it does not have low blood volume yet. The next map you're going to see is the mean transit time, the MTT map. This is a very helpful map. This is showing you how long it's taking the contrast to get through the capillaries in the brain. So it's really the capillary transit time. And in somebody who's having an acute stroke, this map should match the pattern that you see on Tmax. In other words, areas that have a delayed arrival on Tmax, and Tmax is very good in showing you the delay in the arrival of contrast. If those same areas have a delay in the capillary time, that tells you that this is an acute stroke. In a chronic vessel occlusion, somebody who's had a chronic occlusion of their carotid or chronic MCA stenosis, you can get Tmax delays, but you have normalized your transit time. The capillary transit time, it normalizes. So this is going to help you determine, is this an acute situation versus this just a chronic blood vessel occlusion or chronic stenosis? So very helpful to be able to look at these maps. All right, let's move on. We are going to get a map now that shows us where the normal blood vessel is being looked at. Remember, it said to generate these maps, we look at where the contrast arrives in a normal vessel, and then we look at how much delay is there between when it's arriving in a normal blood vessel in the brain and when it's arriving in the brain tissue. So the normal vessel will be chosen on the opposite side of the occlusion. So here, if you look at the middle cerebral artery on the left, you can see that that's occluded. So the red dot is what the software is finding to be a normal blood vessel in the brain. And that's how you're going to set the clock. So you want to make sure that's in a good location. If the patient's moving during the scan, maybe the red dot winds up in a place where it shouldn't. It's actually easy to move that. You can erase it and put it in a new spot. And here you can see it's in a very good spot. It's in the junction between the right carotid and the right middle cerebral artery. All right, so the AIF is in a good spot. And then we want to look at the curve of the AIF. So here, the red line is the arrival of that contrast into that normal blood vessel. And here, what we can see is that there are some problems. If we look at the left of the graph, we can see there are two vertical dotted brown lines, and they're separated by about 13 seconds. The x-axis is the time axis. And what that means is that we didn't start scanning this patient. We started scanning this patient with a radiation for about 13 seconds before that contrast arrived. And we'd rather not do that. We'd rather just scan for a few seconds before the contrast arrives. And the reason, if we don't time it well, is that we may not capture the whole process of the contrast going in and out of the brain. We captured all the red curve, but you can see that the blue curve has been truncated. We missed the end of the blue curve. And that's because we started scanning way too soon. The other thing we see on the right side of this slide is how much movement occurred. We can see rotational movement and we can see translational movement in the X, Y, and Z axis. And movement can cause artifact. So it's nice to see that there's not movement, but if there is, and it occurs after the bolus is out of the brain, then you can remove the movement, which is a simple procedure to delete the frames that have movement. So let's take a look at a good AIF. This is what you're hoping to see. So here we can see on the left of the screen with the two waveforms that those two vertical brown lines are close together. If you only see one vertical brown line, that means the contrast already arrived before you started scanning. That would also be technically inadequate. So this is perfect. We see that we've got about 2 seconds of baseline. You need a normal baseline to have a good quality perfusion imaging. So here we've got, a nice short period of baseline. Then the contrast bolus arrives, and we see a very nice peak of the red arterial input, a nice peak of the blue venous output. And we see that all of the contrast is out of the brain by 30 seconds, which means if there was movement, and in this case there wasn't, but if there was movement after 30 seconds, we could delete those frames and it would not affect the quality of the image because all of the information we needed here was captured within 30 seconds. All right, so let's talk about a couple of limitations. One of the most important one, and one that is often not appreciated, is that CT perfusion is going to give you a snapshot of the blood flow to the brain at the moment you do the scan. So it's going to show the hemodynamics of that patient at the moment of the scan, but it does not tell you what happened yesterday or 5 hours ago. Suppose you occluded a blood vessel yesterday and now the blood vessel is open and the blood flow is returned to normal. There may have been damage yesterday, but now there's normal blood flow. So CT perfusion is not imaging dead tissue like a non-con CT is. It's showing you blood flow. And once you return the blood flow, you can actually have normal blood flow in dead tissue for a while because the tissue may be dead, but the blood vessels are open. So this is a typical example here of somebody who comes in with a left middle cerebral artery occlusion. You can see that big green area in the left hemisphere there. That's all the area that has critical delay in the arrival of the blood flow, more than 6 seconds delay, likely to go on to die if you don't do something about it. But fortunately, the pink area that has very low cerebral blood flow is teeny tiny, right? So this is a very large mismatch. A small pink and a big green is highly desirable for the patient. Now, what happened at 4 hours is somebody like Lucy pulled out a blood clot and restored the blood flow. And you can see the blue line. The blood flow is not only going up to normal, it's going up above normal because during the time of the stroke, the blood vessels are maximally dilating, trying their best to get blood flow to the area of the stroke, and they don't vasoconstrict very quickly because they've lost their autoregulation during the time of the stroke. So you can actually get high blood flow right after reperfusion. At 24 hours, the blood flow has come down into the normal range. So the CBF map looks normal, but there is a stroke. You can see that pink area is now obviously infarcted on the non-con head CT, but the blood flow in the area is only minimally reduced because the blood vessels are still alive. They haven't gone on to die. So that means the pink area is going to disappear. So the fact that there's no pink after reperfusion does not mean there's no stroke. It just means the blood flow has been restored to the area where the stroke is, and you need to look at the stroke on a non-con CT or an MRI scan. So the stroke is going to appear to disappear once you reperfuse the vessel. All right, here's one where you're going to look at 24 hours in somebody who's had a very bad stroke with very poor collaterals and see how things evolve in this patient who did not have recanalization of the vessel. So at 2 hours, this patient looked exactly the same as the last example, left MCA perfusion deficit, small core. But the blood clot is not removed in this case. So by 8 hours, you can see that that area of very severe low blood flow, the pink area, is growing, and you're starting to be able to see the stroke on the non-con CT. You can see that the green area is also growing because the collaterals are failing, and the green area of critical hypoperfusion is getting larger. By 24 hours, that green area is still very large, but what has happened now is that there has been a lot of collateral recruitment along the cortex. So collaterals have come in and improved the blood flow, but it's too late. It's futile collateral recruitment because that tissue was already dead. And in fact, that tissue has gone on to have very low Hounsfield unit. And because of the very low Hounsfield units, the program will not color it pink anymore because it is now looks like an old infarct. The color pink is reserved for the new infarcts. If it's very severe reduction in Hounsfield units, very dark, the pink is not going to appear. So as you get out towards 24 hours, the pink can disappear because collaterals can bring in more blood flow, and the blood flow is no longer reduced by 70%. It also can disappear because the Hounsfield units are now very low, and it's looking like an old infarct. So you're going to see the stroke better 24 hours later with a non-con CT than with the CT perfusion. Okay, I've already mentioned that very important perfusion delays can occur even if it's not green because the delay is less than 6 seconds. So here's an example. Somebody was 52-year-old, stuttering right arm weakness and language difficulty, is normal now, having repeated TIAs, but they're normal at the time of the scan. So if you look to the left, the mismatch map here, it looks pretty normal on first glance. But if you look more closely, remember that on the right side of the mismatch map, the ventricles are white and delays and blood flow are white. So if you compare the left side of the brain to the right side, you can see that the left side is a bit brighter. And you can see on the Tmax 4 threshold map on the right that there are delays in that left hemisphere, but they're in the blue range. They don't show up in the mismatch map because they're not more than 6 seconds. That would make them green. They're between 4 and 6 seconds, but they're still important because if you look at that pattern, this is a watershed pattern. And you see that pattern, it is pretty suggestive that there may be a high-grade stenosis or an occlusion of the carotid on that side. And what happened to this patient is the next day, the patient got much worse and was found to have a left carotid occlusion. So that high-grade stenosis went on to occlude. This is the image column at the time the patient was normal. And again, when you look at the image column on that Tmax column on the right, it should be pretty easy to tell that the right side of the brain has delays. It's got those brighter yellow colors, and it's in a watershed pattern. So that should tip you off that even though the mismatch map didn't measure any abnormal volumes or have any abnormal pink or green, that this is a patient, there's a problem in the carotid system, and you want to take a close look at that left carotid. Okay, so how to avoid overestimation of penumbra? I've already mentioned that you can get a lot of help from the mean transit time map. So the Tmax map, that 6-second delay, is highly likely to represent irreversibly injured tissue in the setting of an acute stroke. However, if you have a chronic occlusion, or you have somebody who's got moya, where they've got slowly occluded blood vessels, what will happen is you have the delay in the arrival because the vessel is occluded, but the patient has compensated for that occlusion. We've got people walking around with carotid occlusions who have no symptoms at all. If the carotid occludes slowly, you can develop collaterals and you may not have a stroke. So in the top, what we're going to see is somebody with a chronic occlusion of the carotid. They still have a Tmax delay. It may even be 6 seconds in some areas, but you can see the MTT, the mean transit time, which was again, that capillary transit time is normal. So they have compensated for this. This does not happen immediately in an acute stroke setting. So below, what you can see is that the MTT, the pattern of the MTT is matching the pattern of the Tmax. That tells us we have an acute stroke. You can also see that in this case, you have that dark blue CBV and the dark blue CBF, right? So that means that the blood flow and the blood volume is very low, where in the chronic occlusion case, we've got normal CBF. And sometimes you even have increased volume because the collaterals are trying to bring in extra volume to compensate for that chronic carotid occlusion. So looking at these patterns can help you differentiate an acute from a chronic occlusion. All right, so hopefully we've learned a little bit about how to interpret CTP, and we're going to finish off by returning to this complicated case that we started out with that had no green and no pink on the mismatch map, but all sorts of findings when we look at these maps in terms of what's dark and what's bright. So this patient presented with left-sided weakness and upper extremity twitching motions. The history is also that this patient had a history of a right carotid occlusion and an infarct in the right frontal lobe. So now if we go back to that Tmax map, we can see the reason that we have a brighter right hemisphere is because this patient has a right carotid occlusion, which they have compensated to some degree for. But at the time of it, it caused a big infarct in the right frontal lobe. So that's why there's that very bright area of white in the right frontal lobe. And then we also suspect that we're going to see some movement on the movement column because we've got that sort of like white pencil line along the front of the brain. Now, if we go over the CBF area, what we're going to see is that area that's black in the right hemisphere. There's going to be no brain tissue there. That's like CSF. But below that, right in the occipital lobe, we see this bright area of elevated CBF. And now we know why that is, because the patient has twitching movements. This is what a seizure looks like. We have increased CBF right along the cortical margins of that right hemisphere. So here we can see that the patient has a good quality AIF, right, on the left. The waveforms look nice. We see just a couple of seconds of delay before the contrast arrives. We see two vertical dotted brown lines, and we see the movement that occurred. You can see that there was a lot of rotational movement that occurred at about 45 seconds, which is actually after the waveform. So if we wanted a little bit cleaner map, we could remove that if we wanted to. And then we're going to see where the AIF was chosen. So you see the red dot shows us that the AIF was chosen from the anterior cerebral artery, which is fine. But the other thing you get for free here is basically another collateral map. Look at all the blood vessels. And if I want to direct your attention to the lower row, what we can look is at the bottom of the right hemisphere, we see some bright white blush. So there is increased blood flow in that area that was seizing. And you can actually see it off this map. Areas without blood vessels, like in that right frontal lobe where there's a big infarct, is going to be black. We don't see blood vessels because there's no tissue there. But in the back of that hemisphere, we see an increased amount of contrast because the blood vessels get dilated during a seizure. Here we see the Tmax delay. And again, the 4-second is very helpful because it's going to show, that bright area of white in the right hemisphere was reflecting a mild delay that has been compensated for in this old carotid occlusion. That's why we have the delay. And then with the CBF, again, we've seen that the black area is the area on the right hemisphere with no tissue. So now we can take a look at the CT scan here in the image columns. And we can see again in the right frontal area, that big area of encephalomalacia. There is no brain there because of the old stroke at the time of the right carotid occlusion. But if you look at adjacent maps, the CBV and CBF maps are the ones next to the non-con CT. And if you look towards the back of the brain, the occipital lobe, you can see that bright yellow and red signal. That's the seizure happening. So, complicated case, but you can see that once you really get comfortable with CTP, you can really get a lot of insights into what's going on with the patient. And hopefully this has helped a little bit in your interpretation of CT perfusion.
Thank you so much, Dr. Albers, for a truly enlightening presentation on the nuances of perfusion imaging interpretation and how it can help with diagnosis and treatment decisions. I think you highlighted the importance of looking at all the perfusion output maps, since there's so much information that can help us understand what's happening physiologically and hemodynamically to that stroke patients. So now we will transition to our panel discussion. And I'd like to have an opportunity here to introduce our panelists once again. We will explore some stroke cases. We're going to focus on the nuances of interpreting the imaging and determining the crucial next steps for that patient. And to lead us through this complex scenario, I'd like to introduce, again, as I said, our esteemed panelists. So first, we welcome Dr. Tom Check, who is the medical director for Matsuboro EMS. He provides the essential clinical leadership and direct medical oversight that guide the life-saving care delivered by frontline emergency responders in Matsuboro. Joining him, we have Dejin Perkins, who is program director for the Alaska Guardian flight. As a registered nurse, she provides extensive leadership and brings deep clinical expertise in the critical field of air medical device services. Also with us is Rick Janik, a nurse with Airlift Northwest, Beyond his clinical work in Juneau, he's deeply committed to systemic improvement, lending his expertise to statewide initiatives focusing on elevating patient safety and standards of care. We're also joined by Kevin Murick, a veteran nurse who has very diverse background, including experience as a medic, as a firefighter, and flight nurse. He's a founding member of the Stroke Coalition and has done so both in Hawaii and Alaska. He brings unparalleled expertise to the development of Alaska's statewide stroke program. Joining him from the coalition is Amber Simonetti, a registered nurse and the accreditation coordinator for chest pain and stroke at Matsu Regional Medical Center. Her work as an executive coalition member is informed by her direct experience implementing high-level stroke protocols at the hospital and ensuring a seamless system of care. We're also pleased to welcome Kelly Isaac as the stroke program manager for Providence, Alaska Medical Center and an executive member of the Alaska Stroke Coalition. She's instrumental in aligning statewide initiatives with the clinical realities of hospital-based stroke treatment. And rounding out our panel, we have Sarah Ransom, Director of EMS Outreach for Alaska Regional Hospital. She's a certified flight paramedic. She plays an essential role in strengthening the partnership between the hospital and Alaska's pre-hospital providers to ensure seamless patient care. So thank you all so much for joining us. And I think we're going to start today then, as I mentioned before, with some cases. And I hope that all our panelists will weigh in. And again, for our audience, please feel free to send us your questions through the Ask a Question button on your screen. So here's our first case. We have a 22-year-old woman with no significant past medical history, with an acute onset headache and left-sided sensory changes. While being transported by paramedics to the emergency department, she develops left-sided weakness. So I'm going to direct my first question here to Dr. Tom Check and Sarah also, if you'd like to jump in. What diagnosis would be considered in the ambulance setting? What would you do when she became weak en route?
As a pre-hospital provider, there are quite a few initial diagnoses that we would want to run through so that we're not missing too many items. The obvious ones for age and for gender would be overdoses, would definitely want to consider stress and consider pregnancy, and definitely have some consideration, especially in this day and age with the reason why we're all here with the stroke seizures, and kind of round things out with the seizure is probably one of the more primary ones.
Great. Yeah, that's very important insights, right? Especially when you have somebody that young. Okay. Here we have additional information. So when the patient reaches the ER, we now have some imaging done. We see a negative non-contrast CT. We have a negative CTA. It is now 3 hours from onset. We have an NIH stroke scale score of 5. Should we be considering thrombolysis? And I'd like to go back here to our panels also. Please jump in. I don't know, Dr. Latta, what would you think? Should this patient be considered for thrombolysis? Well, please go ahead.
I can jump in. Yeah. So when we're looking at these patients, as far as lytic, there's 3 things I always tell folks to at least think as a checklist. So number 1 is this a stroke? And so that aspect has to be decided on. If you believe it's a stroke, then you have to determine whether that is a patient who's a candidate for thrombolysis. And then third is whether they are or not a candidate for thrombolysis, you have to determine whether they're a candidate for thrombectomy. And so I think part of it is there's certainly a high potential for stroke. Though there's other differential diagnoses that are there. So I think part of it is, looking at, could there be anything else that one would be a contraindication for lytics, and, going through that checklist. But in general, if we're finding a patient and, from the telemedicine side, we'll frequently do this. We'll have a non-contrast head CT that's normal, CT angiogram that's normal, history that doesn't help me define whether this is clearly a stroke or not. And then if nothing else is clearly moving me in a different direction, like seizures or migraines, then as long as it's not a contraindication, we'll frequently give that. We'll frequently consider thrombolytics. But obviously, there's additional questions and details that we would need before the final decision.
Let me ask you in general for nurses in our panel, Amber and Kelly and Kevin, please. What are the pros and cons of treating somebody like this with thrombolysis? I mean, Dr. Latta already mentioned a few things, but what are your concerns from a nursing perspective?
So I think as we look at this case, of course, I always defer to the experts of our esteemed physicians and all of their decision making. In looking at this case, so we know that strokes can happen at any age, and when you're young, if you have lingering deficits, that's the rest of your entire life that you're working through those things. We also know that you often don't have the ability to have all of those collaterals built in because of your typical lack of chronic diseases. And so some of those cases can be really devastating. And so that's certainly part of it. The other part of it, of course, then is that there are risks inherent with giving lytics to patients. And so we want to make sure that we are prudent in our judgment. And one thing that we always talk about is really making sure that it's shared decision making. And so you are, if able to discuss it with the family and making sure that they understand if this is a disabling deficit for them. And what they would like to do with it. So really, really exercising that shared decision making in any case that it's possible. And if not, then really working together as the clinical team between neurology and ED providers, including the nurses or family if possible.
That's great. Thank you. Appreciate that feedback. So let's see what's actually happening with this patient, right? So shortly thereafter, she developed confusion and visual symptoms. So at this point, what is your differential diagnosis? What would you do next? And what would be your differential diagnosis at this point?
Well, stroke is high on the list, but atypical migraine is also a possibility for this patient.
Yeah. Okay. So that's. I think that you're on the right track here. So let's see what actually happened. This patient was actually treated with TPA. These are all real patients, by the way. This patient was treated with TPA. And then here we have the CBF map from CT Perfusion. And I'm going to call back on Dr. Albers since he is the expert on perfusion. So Dr. Albers, can you walk us through this particular map?
Absolutely. Hopefully you can still hear me.
Yes.
Yes. So, agree with all the comments that the panelists have made. There was no contraindication that was immediately apparent for this patient. So treating her with TPA was certainly reasonable, but then having additional symptoms after TPA is obviously very concerning. One of the things one would obviously be worried about was, did she bleed? But there's been an evolution in the symptoms here. We started with sensory, moved on to motor. Now we're on to confusion and visual. So this type of a march is very typical for a migraine. And what you can see here is something that's not captured all that often, is that in the midst of a migraine, you can have elevated cerebral blood flow. And that's what's showing here. And again, this is not a pattern of a stroke where we typically see a more wedge-shaped deficit from occluding a middle cerebral artery. This red area is hugging the cortex. It's starting in the occipital area between the hemispheres, and then it's hugging the cortex, sparing the white matter. So this is much more typical of either a seizure or a migraine. And in this patient, the history is more typical for a migraine. And in fact, this patient had a strong family history of migraine on the mother's side, but this was her first migraine. So her first presentation of migraine was a complicated migraine with neurologic symptoms.
Well, thank you so much. This is, again, very, very enlightening case. And I wanted to ask, Rick, Janek, how often do you see this, or have you encountered patients like this in your EMS program?
Yeah, hi, thanks. I think that the stroke mimic for transfer is probably pretty rare, right? And so, or stroke mimic or stroke chameleon. But patients that have complications, either from thrombolysis or patients that we are moving to get towards mechanical thrombectomy are common. If I could, maybe Carolina, maybe 3 different questions that I like to ask or think through and share with others is, one is, what else could this be? And I think Dr. Check and others have already spoken to that. Is it possible that there's more than one thing happening? And so again, with these waning symptoms that Dr. Albers talks about, and then is there anything that doesn't fit? And that's kind of how I process the case when I'm meeting a new physician with a new patient and we're trying to move for speed. Those are some of the things that I'm typically thinking about. Hopefully I answered your question. Thanks.
That's great. That's great. No, that's fantastic input. So now let's continue on to our next case, and let's see if we can apply those questions that you just raised and your thinking process to the next case as well, Rick. Thank you so much. So now we have a case number 2 is a 50-year-old man with a history of poorly controlled hypertension, presents to the ER with acute onset of vertigo, nausea, and mild headache. No weakness, numbness, or other neurological symptoms. The blood pressure is 165/95. And the neuroexam, he shows some nystagmus. He's unable to walk because of severe vertigo, but has no other neurological abnormalities. So what would be the differential diagnosis if you get called in to see a patient like this, Rick?
Yeah, I mean, from my time in the ER, the red flag for me in this patient is always a posterior circulation stroke. And part of that is a little bit of experience. It's one of those things that if you miss one, you're never going to miss one again. And so for younger clinicians or folks that haven't seen those, when I see these kinds of things, balance eye complaints, I always think posterior circulation.
Great. And thank you, Rick. And then I want to go to Sarah Ransom. Sarah, would you treat this patient's blood pressure during transport? Tell me a little bit about your experience, how you guys work, and what do you do about the blood pressure? So please jump in. Tell us a little bit about your experience and how you handle, since you transport patients not only by ground, but also by air.
I very much appreciate that these chronic conditions, sometimes the permissive hypertension is very useful. And this blood pressure specifically still fits well within a range of safe transporting for both subarachnoid bleeds and for the ischemic strokes. So we would not treat this either until we get a better clinical picture or some more information.
Let me go back to Dr. Tom Check. Dr. Check, would you treat this patient's blood pressure during transport?
No, because we don't have a diagnosis right now. And we know that for some strokes, permissive hypertension is a treatment. And so since we don't know if this is a thrombolytic candidate, we don't need to get that blood pressure down right now.
Okay, great. So let's look at what's happening. What else is on the clinical picture? So ER evaluation, again, like the patient before, we have a negative non-contrast CT. We also have a negative CTA. Now we're 4.5 hours from onset, and the NIH stroke scale score is 0. And should this patient receive thrombolysis? I think we've just talked about that a little bit, and there's hesitation here. So let's find out what else is going on with this patient. This patient was diagnosed with peripheral vertigo and treated with antivert. The neuroconsultant recommended a CT perfusion prior to discharge, which was performed 6 hours after onset. So what is your differential diagnosis? What would you do next? Do you agree with the CT perfusion, Dr. Latta?
Yeah, so we get this a lot, and I think it's probably one of the most frustrating and challenging diagnoses when someone comes to the emergency department, and we're on the telemedicine side, the ER doc as well. Dizzy, unbalanced patients go to the emergency department every day. And so how do you tease out the ones that you need to be concerned about? From the very beginning, there was one comment that was made in regards to walking. And on the other aspect of it, there was an NIH stroke scale of 0. And the NIH stroke scale does a very poor job with identifying posterior circulation strokes. Although, you're looking at ataxia, a lot of folks can have bilateral cerebellar infarcts and not have much ataxia, but they can't walk. And so one of the things that we'll frequently do as telemedicine side is getting the patient to stand and walk. And in general, when I see patients who have tremendous vertigo, or any kind of vertigo, but really are struggling with ambulation, that is a red flag for me that we need to dig in. So my assumption is that someone got this person standing and made that recommendation to take a look at additional imaging, something that's more functional and something that's more objective. Other centers who have the ability to do, really rapid MRI scans to take a look of trying to get something that's objective. The problem with at least MRI scans that in an early setting like this, it may be completely normal, especially with a brainstem stroke. And so getting something that's more functional that gives me gives me a little bit more confidence to let that patient be discharged. So I would go forward and get something that's more functional to see, in me functional in the stand up, not as a patient. We use that functional diagnosis that there's a psychiatric issue, but more functional of looking at the pathology at real time. And that can really help make decisions.
Fantastic. Thank you so much. So let's actually see what happened next here. So let's look at the CTP results here. So here we are. What is the diagnosis here? And should this patient receive thrombolysis? Let's go here. Let's see to Dr. Albers.
Yeah, this is a tough case. And as mentioned, we see this all the time, that people come in, it looks like it's peripheral vertigo, and you don't want to miss a cerebellar stroke, because a cerebellar stroke, can swell up and compress the fourth ventricle. They can be back in a couple of days with hydrocephalus. So it's a gigantic medical legal issue as well as a clinical one to sort these out. So here you can see that there is a perfusion deficit in the pica territory of the right cerebellum. So, and this was confirmed on MR in this patient as well. So this is clearly a cerebellar stroke that was, initially misdiagnosed as peripheral vertigo. Sometimes the neuroexam can give you some hints. There are some differences in the way that the nystagmus looks in central versus peripheral vertigo. I think the point was excellent about the gait abnormalities. If there's a bad headache, that is also something that's less typical in benign vertigo and more common when you're having a stroke. So there's some clinical hints, but sometimes it's just impossible to tell without the imaging. So CT perfusion can be a good screen as long as your protocol is capturing the cerebellum. Some CT perfusions, we see that the cerebellum gets missed. And as mentioned, the brainstem can be hard to see on either perfusion or even on MR. If you're doing an MR, it's critical to do a diffusion sequence because that's the most sensitive to picking up an acute stroke in the posterior circulation. So this patient is having a stroke, but it was 6 hours in. And so beyond 4.5 hours, we don't have clear indications to give IV thrombolysis. There are studies that show you can extend the window in certain patients with a perfusion mismatch. But in this patient, the infarct, fortunately, is relatively small at this point. So we would not give thrombolysis at this time.
Great. Well, thank you so much. Okay, so now we're going to go to case number 3. And we're going to challenge some of our audience members also, if you have some questions or if you have some thoughts on how to treat this patient or understand, first of all, what the diagnosis is. So here we've got a 76-year-old woman with a history of diabetes and chronic back pain, presents to the ER within 12 hours of right leg weakness and numbness. On the exam shows mild to moderate weakness and numbness of the right leg, but no other neurological abnormalities. So what is differential diagnosis? What imaging would you order and would you treat blood pressure in a patient like this? So I'm going to go to Dr. Cass here. What would be your differential diagnosis with just this information at this point? And what imaging would you order?
So clearly, this is just not a classic stroke presentation because the weakness is only in the leg. And she does have the history of diabetes and the chronic back pain, which could be a sign of radiculopathy or some bulging disc. So that's what I would think first, because it's just very unusual for a stroke to present with just leg weakness without any involvement of face or arm.
Excellent. Thank you. So let's see what's happening next to this patient. So now the patient is being evaluated in the ER. Once again, we have a negative non-con CT and a negative CTA. This patient is now 12 hours from onset. We have an NIH stroke scale score of 3. And what additional imaging would you suggest, if any? So let's see. Let me go to Dr. Lada. Dr. Cass, I'm going to go back to you. If you can let us know, what would you do here in this case?
Most likely, I would start with an MRI of the lumbar spine.
An MRI of the lumbar spine. Okay. And Dr. Albers, any thoughts?
I agree. Let's get the MR of the lumbar spine and see what we find.
Okay. Well, let's take a look.
Carolina, this is Rick again. Just a quick question for the panelists with their expertise for adding a little bit of an Alaska mix. Would you move the patient to get that image? You know, if they were 400 miles away from an MRI or how would you help us with that recommendation? Personally, I think they still need to go, but I'm just wondering your guys' thoughts.
Excellent question, Rick. So Dr. Albers or Dr. Cass, or Dr. Latta, would you actually move this patient? Would you transport this patient to a different facility to get that MR if the facility they were in was not able to do that?
And yeah, I think the challenge up here is always, the question of using resources and moving somebody. I think part of it is trying to get, that's where, the ability to get a good exam is really critical. And a lot of sites, this is where I'm a big proponent of telemedicine, of having, in these kind of settings, to have somebody get eyes on that patient. So if it's a lumbar issue and the exam looks that way, then no, we wouldn't do that. If we don't have that information, then we're obligated to move that and look for the more critical issues. So is this an anterior cerebral artery stroke? Is this an ACA stroke that's just presenting with lower extremity weakness? And usually by exam, we can start to identify some of those issues by talking to that patient. But I would say that in facilities that don't have telemedicine capability to have neurology or telestroke beam in, I think we're obligated to move these patients with this type of weakness, with this level of disability, to identify things.
Excellent. Thank you. So in this case, the patient does have a lumbar MRI. The MRI shows degenerative changes, but no nerve root compression. Dr. Albers, what would you do next? What's the differential diagnosis here, and what would you do next? What would be the next step?
Yeah. So one thing you could try on the exam in terms of the question of, are we moving this patient or not, is looking for any signs of radiculopathy on the exam, right? Straight leg raising sign. You can be looking at reflexes, trying to look at a sensory distribution, trying to sort out, am I seeing something that's looking more peripheral? The MR is not showing us that. So with a leg that's that weak, 3 points on the NIH stroke scale from one leg, it has to raise the possibility that's already been mentioned, that the one type of stroke that is known for giving you just leg weakness without face or arm involvement is the anterior cerebral artery. It's not the most common spot to have a stroke, but the anterior cerebral artery goes right along the motor strip in the leg region. So you can get unilateral leg weakness from a stroke in that area. And so certainly I'd want something, again, like we had before with the Vertigo case, either we need an MR or a CT perfusion to try to rule out an anterior cerebral artery stroke.
Excellent. So let's take a look what happened here. So now let's look at the CT perfusion results. And I think Dr. Albers, you're right on the money here. Can you tell us a little bit about what you see on this CT perfusion mismatch map?
Yeah, so this is the territory of the anterior cerebral artery on the left. It can extend further back as well. And you can see that there is already some infarct that's showing up here now on the CTP in that same distribution. So unfortunately, this patient is beyond the window for thrombolysis. An ACA is a vessel that we typically do not do thrombectomy on. There were trials that were released last February showing no benefit from thrombectomy in anterior cerebral artery infarcts, particularly with low NIH stroke scale score. So again, unfortunately, this patient, we have now confirmed that she's had a stroke. So we're going to be looking at why she had the stroke and stroke prevention measures, but she's beyond the window for thrombolysis. If she'd come in very early and this was picked up, we could have treated her with thrombolysis. But it's a good example of a stroke chameleon. It looked like a lumbar spine problem, but it was actually a brain problem.
Thank you so much, Dr. Albers. And Sarah Ransom, like, how often do you see, or have you seen cases like this that you've had to deal with? So where the symptoms are not really clear and a little bit challenging to ascertain what to do next?
Yes, I think that pretty frequently at the hospital, we always venture on the side of caution. And so if they come in with symptoms, anything to do with leg weaknesses or things of that nature, we try to take them quite seriously. And we run a lot of stroke alerts to confirm that we're not missing something.
Wonderful. Thank you so much. Well, this was an excellent discussion, and I hope that our audience and really learn the importance of the image interpretation and actually looking at all of the maps in perfusion, and also the challenges, right? The pros and cons of using just clinical symptoms and the need to do some imaging to really help you hone into the right diagnosis. So I think we're going to move next now.
One last point,
yes.
Carolina, is that, oftentimes the community hospitals think, oh, I don't need perfusion, it's too advanced. But any scanner that can do a CTA can also do a CTP. So what we've found in Northern California is that even the small community hospitals that have adopted CTP have found it to be incredibly useful, oftentimes being able to avoid transferring patients either who don't have a stroke or have stroke that can be managed locally. So it can be very helpful in figuring out at the community hospital level what's wrong with the patient and preventing an expensive transfer. So worth considering for some of the hospitals that they have thought, oh, I don't need to do it. Their scanners can do it. It's not a big deal to add that on.
That's a really important point, Dr. Albers. I really appreciate you bringing that up, because we do hear about community hospitals or rural facilities that are, whose teams are very concerned about doing the imaging. But then how do we help those rural hospitals that say, well, we can do the imaging now, but how do we interpret that? If we don't have the expertise to interpret the imaging at our site, then how do we handle this?
Yeah, so that's the advantage of having a AI software where somebody who's in Anchorage can see the images of the outside hospital. At Stanford, we have 10 referring hospitals where we see the images in real time. So the same time they know about a case, we can see it as well. And when they call for help, we can give much better information because we have access to the images through the AI app. So I think that's very helpful to have a team approach where you can have experts viewing the images that come out of those community centers. You can also have AI from a non-con CT, right? That you can pick up hyperdense vessel sign and LVO detection, even if you're not doing even a CTA. If it's a very rural hospital, all they can do is a non-con CT. You can learn a lot from hypodensity aspect scores and hyperdense vessel sign.